So pleasant day, dear doctors, and welcome to our CDB e-tutorials. For this session, we will be giving a rapid but very high yield coaching about the correlative anatomy of the upper extremities. So this is Doc Toom, and thank you for joining us for this session. Now, these are the basic house rules. So first, all microphones of all of the participants will be muted during the lecture or coaching proper. Please use your reaction icons, the thumbs up, the smiley, the sad face, the shock face, the what. And please participate in polls if there are any. All videos should be on, otherwise you'll be removed from the room. So this is your master guru. This is Doc Toom. I'll be utilizing the following references for this e-tutorials. I'll be using a mixture of clinically oriented anatomy by Moore and clinical anatomy by regions by Richard Snell. Now, there will be some board recall coming from B.R.S. Gross Anatomy, and a lot of the reference illustrations and figures will be lifted from Frank Netter's Atlas of Human Anatomy. Now, usually when we think about anatomy, a lot of people would probably end up looking like this. Highlight, underline, making post-it notes, making your own little notebook, and you're approaching anatomy in the wrong way. Now, let's go straight and teach you the must-know pearls you must bring with you to any standard anatomy examination. So let's begin this session by talking about the humerus. Now, just some important structures to highlight. So first, this is the head of the humerus. We have two very important projections here. One is the greater tuberosity. The second is the lesser tuberosity. Then we have this structure, which is highlighted in yellow. This is the surgical neck. Now, if the examination is going to be 5 minutes from now, the most important thing you have to bring with you is going to be the surgical neck. Why? The surgical neck is a very common site for fractures of the humerus. And there's a very important structure that everyone has to memorize. If the surgical neck is fractured, then what important landmark structure would also be injured? This is going to be the axillary nerve. Now, question, what shoulder muscle is innervated by the axillary nerve? Let's see your answers. Okay, very good. There are two important shoulder muscles which are innervated by the axillary nerve. First is going to be the deltoid. Second is going to be the teres minor. Okay, again, the deltoid and the teres minor. So how can we convert this into a correlative or clinical case scenario? If someone is reported to have injured himself and there is a documented fracture of the surgical neck, what muscles would you expect to be either paralyzed or atrophied? So it's either going to be paralysis, that would be the acute manifestation, or a chronic denervation manifestation, which would be atrophy. Now, the surgical neck of the humerus is very close to the axillary nerve, as you can see here. Now, question, which of the following nerves is usually injured during an intramuscular injection of a vaccination in the arm? Which of the nerves are usually injured when there is an intramuscular vaccination? Okay, which of the nerves? It's going to be the axillary nerve. Okay, it is going to be the axillary nerve. Now, question, what do we call the pattern, okay, of the sensory involvement? What do we call the pattern of the sensory nerve impairment when the axillary nerve is going to be damaged or injured during an intramuscular injection? The military patch is actually partly correct, but we call this the regimental patch. Okay, the regimental patch. If you notice, military people, particularly officers, they would usually have a patch. Okay, for example, they're going to place their stars here or a patch in this area. So that's the regimental. Yes, the military patch is actually going to be correct. Now, another thing to remember for your examinations, this is the anterior view of the humerus, and this is the posterior view of the humerus. Anteriorly, you're going to see the deltoid tuberosity. Posteriorly, you're going to see the radial groove. Now, this is the shaft of the humerus. Always remember the deltoid tuberosity serves as the site of attachment of the deltoid muscle, while the radial groove, as the name implies, is the groove where the radial nerve is going to pass. Now, please take note, the radial groove is oriented obliquely. This radial groove is also known as the spiral groove of the humerus. So please take note of this. Now, look at this illustration. If there is an injury or a fracture of the humerus, it's most likely going to be in this area, which is the surgical neck, or it's going to be midshaft. Now, if there is a midshaft fracture of the humerus, what nerve is damaged? So if there is a mid-shaft fracture of the humerus, it is going to be the radial nerve. Now, question, if the radial nerve is damaged, what do we call this palsy? What do we call this palsy? Now, the wrist drop is correct, but there is a specific name for a radial nerve palsy. The radial nerve palsy is also known as Saturday night palsy. Okay, this is also known as Saturday night palsy, as well as the honeymooner's palsy. Okay, Saturday night, had a night of partying, drinking, went home drunk, you fell asleep on your arm, and when you wake up, you're going to get that numbness along your arm, along the distribution of the radial nerve. Honeymooners making out, and the following morning, they lie down in each other's arms. Okay, so that's the honeymooners or the Saturday night palsy. Now here, you can directly see a fracture of the midshaft of the humerus. So clinically, yes, you are very correct. This is the wrist drop. Okay, this is the wrist drop. Now, what is the description of a radial nerve palsy, which we also call a Saturday night palsy, okay, which is, of course, a wrist drop? What is the description of the extremities? There is going to be loss of extension of the fingers. So what's going to happen is these fingers are going to literally flex, like what you see here. there's going to be loss of extension of the fingers, the thumb, and particularly the wrists. There will be a sensory deficit, and it's going to be numbness along the first dorsal interosseous muscle. Now, question, what is the first finger? Is it the thumb or is it the pinky? What is labeled as finger number 1 or digit number 1? It's going to be the thumb. So anticipate examiners presenting wrist drop without mentioning wrist drop by giving you this anatomic description. Loss of extension of the fingers, the thumb, and the wrists, and numbness of the first dorsal interosseous muscle. Now, look at these two important structures. Now, can anyone tell me what is going to be the tendons which are attached to the lateral epicondyle? Is it going to be the common flexor tendons, or is it going to be the common extensor tendons, the flexor muscles, or is it going to be the extensors? So for the lateral epicondyle, it's going to be the common extensor tendons. So I want you to touch right now where your lateral epicondyle is. This is where the common extensor tendons are going to be attached. Now, what about the medial epicondyle? Touch the medial epicondyle. What is going to be found there? It's going to be the attachment of the common flexor tendons. So please take note of that. So again, touch the lateral epicondyle and the medial epicondyle. In the lateral epicondyle, you will have the common extensor tendons. In the medial epicondyle, you will see the common flexor tendons. Now, question. If there is lateral epicondylitis, listen well, lateral epicondylitis, is this a golfer's elbow or is this going to be a tennis elbow? Okay, so please take note, it's going to be a tennis elbow. Now, always remember the radial nerve is going to be in close proximity to the lateral epicondyle. Now, what nerve is going to be in close proximity to the medial epicondyle? What nerve is going to be in close proximity to the medial epicondyle? Okay, perfect. It's going to be the ulnar nerve. The ulnar nerve is in close proximity. Okay, the ulnar nerve is going to be in close proximity to the medial epicondyle, while the radial nerve is going to be in close proximity to the lateral epicondyle. Now, look at the yellow structure. This is the ulnar nerve. Look at the close relationship of the ulnar nerve with the medial epicondyle, and a very beautiful illustration showing you the flexors being attached to the medial epicondyle. Okay, and look on this side, letter B. This is if you have a fracture here. Let me put an X here. Fracture of the medial epicondyle would lead to damage to the ulnar nerve. Now, look at the bones of the elbow. Here's the lateral epicondyle. Let me put an X here. Here's the medial epicondyle. Let me put an X there. Here's the radius, articulating with the lateral epicondyle. Here's the ulna, articulating with the medial epicondyle. always remember, okay, again, always remember the radius is lateral. The ulna is medial, okay? Always remember that anatomic orientation. Now, for the tennis elbow, is the tennis elbow a lateral or is it a medial epicondylitis? What is the tennis elbow? Okay, let's engage everyone. Let's see all of your answers. Is it going to be lateral or medial epicondylitis? Okay, so always remember the tennis elbow, like a backhand, that's lateral epicondylitis. Now, what about golfer's elbow? A golfer's elbow is going to be medial epicondylitis. Okay, golfer's elbow is medial epicondylitis. Now, the elbow joint, just some must-know facts. These are the specific bones that articulate and take part of the elbow joint. We have the trochlea and the capitulum. The trochlea and the capitulum of the humerus. And don't forget, there's the trochlear notch as well as the head of the radius. So what type of joint is the elbow joint? What type of joint? It is a synovial hinge joint. Now, can you give me another example of a hinge joint? Can you give me an example, another example, aside from the elbow? Okay, an example of a hinge joint. Okay, example of a hinge joint. So we have the elbow. I'd probably put that number one. I'd probably put number two as the knee. Okay, the knee, yes, the ankle, particularly the tibiotalar joint of the ankle. Okay, so those are examples of hinge joints. Okay, examples of hinge joints. Now, can you give me an example of a pivot joint? An example of a pivot joint. Okay, what is an example of a pivot joint? Okay, yes, the radius and the ulna, radial ulnar is very, very pivot. Okay, the neck, okay, correct, the atlantoaxial or the neck. Okay, now, what about a gliding joint? What is a classic example of a gliding joint, especially in the hand? What gliding joint do we have in the hand? Gliding joint. Okay. What gliding joint do we have in the hand? We have the wrist. Okay, the wrist is a gliding joint. Okay, the wrist is a gliding joint. Now, everyone must memorize this. Of all of the ligaments involved in the elbow, what are the three most important ligaments? These are the ones that are usually injured in trauma and in sports-related events. What are the three most important elbow joints? Okay, again, what are the three most important elbow joints? Elbow ligaments, rather, the three most important. So here, we have the annular ligament, we have the lateral ulnar, then we have the medial collateral ligament. So the medial, that's the ulnar collateral ligament. Then we have the lateral, that's the radial collateral ligament. And of course, we have the annular ligament. I strongly encourage you to be familiar with these three joints, three ligaments, okay? of the elbow joint. So let me rephrase. Be familiar with these three most important ligaments of the elbow joint: medial ulnar collateral, lateral or the radial collateral ligament, and the annular ligament. Now, of those three ligaments, the one that is a fan favorite to come out in any exam is the medial or the ulnar collateral ligament. Why? It is closely related to the ulnar nerve. Again, it is closely related to the ulnar nerve. Okay, it is closely related to the ulnar nerve. So please take note of this. Okay, it is closely related to the ulnar nerve. That is what you have to remember by heart. Okay, that is what you have to remember by heart. Now, next, difference between an anterior and a posterior elbow dislocation. Question: which is the most common? Which is the most common type of elbow dislocation? Is it anterior or is it posterior? Okay, very good. A posterior dislocation is more common in the elbow. Now, what about the shoulder dislocation? What is the most common if there is a shoulder dislocation? It is usually anterior. Okay, now look at these photos. This is a classic posterior elbow dislocation. This is the radiograph of a posterior elbow dislocation. Now look at this. Look at that. Okay, painful or not. Then, of course, look at that. These are classic posterior elbow dislocations. Now, question: where are elbow dislocations more common? Are they more common in children or are they more common in adults? Where do you usually encounter elbow dislocations? In children or in adults? Now, if you read the textbook, elbow dislocations are more common in children. They are more common in children. So please take note of that. Now, what do we call this condition wherein the radial head is subluxated? There's subluxation of the radial head or dislocation of the radial head. And this is because of a sudden pull, okay? A sudden pull on the extended pronated forearm. This is what we call a pulled elbow. This is known as a nursemaid's elbow. So what is the clinical significance of a nursemaid's elbow in children? What does it usually indicate if there is the presence of a nursemaid's elbow in children? It usually indicates a possible or a suspicious form of physical abuse. Okay, physical abuse. So please take note of this. Radial head subluxation caused by a sudden pull on the extended pronated forearm. So please take note of this. Now look at this very, very important figure. Let's orient ourselves. Here's the humerus. Here's the radius. Here's the ulna. If there is a supracondylar, I'm encircling it right now. If there is a supracondylar fracture, what nerve is going to be most likely injured. Again, supracondylar fracture is usually associated with damage to the median nerve. And the median nerve supplies the thumb, the index finger, and half of the middle finger. That is the median nerve innervation. This leads to what we call the ape hand, also known as the simian hand. Ape or the simian hand. Okay, so supracondylar fracture is associated with injury to the median nerve. Chronic median nerve injury leads to atrophy of the thenar eminence. Now, I want you guys to look at this. Okay, so let's bring this up. Hold your hand in front of you. Wiggle the thumb like this. Again, put your hand in front of you. Wiggle the thumb like this. Now look, this is the thenar. This is the hypothenar. So where is the thenar eminence? The thenar eminence is here near the thumb. It is thumb. Thenar. Thumb. Thick. It is thick. It is thambok. Okay, so this is where you're going to see the thenar eminence. So chronic median nerve injury leads to atrophy, which is now known as the ape hand or the simian hand. Now, take note, a supracondylar fracture also can injure the brachial artery. And this is what we call in clinical practice as a pulseless hand. You also have to be careful in this area because the muscles of the arm as well as the forearm, they are arranged in compartments divided by fascia. Now, if I tell you there is going to be pain, there is going to be pallor, there is going to be paresthesia, and there's going to be pulselessness. What is your diagnosis? Pain, pallor, paresthesia, and pulselessness. The first manifestation is usually pain. This is most likely compartment syndrome. And what is the definitive management of compartment syndrome? So there's going to be compression of the neurovascular bundle. That's why there's going to be pallor, pulselessness, and paresthesia. So treatment, okay, the treatment or definitive treatment is going to be fasciotomy. Okay, fasciotomy. You're going to open up that fascia to hopefully save that limb. Now, question, what do we call this ischemic contracture that you see in the photo? And this ischemic contracture is usually associated with a supracondylar fracture. What do we call this fracture? This is known, so this fracture is a supracondylar fracture, but the contracture is known as a Volkmann's ischemic contracture. This is a Volkmann's ischemic contracture. Now, question, what is the blood vessel that is affected, which leads to the Volkmann's ischemic contracture? This is a cut in the blood supply. That's why it's called ischemic contracture. What blood vessel is affected here? It's the brachial artery. So always remember, what are the structures very close to the supracondylar area? Give me the two structures, very important structures, which are very close to the supracondylar area. Number one is the median nerve. Perfect. Median nerve. Second is going to be the brachial artery. Okay, now everyone should be familiar. Everyone should be familiar with the Volkmann's ischemic contracture. How does it look? How is it described? So there's going to be flexion of the elbow. The forearm is going to be pronated. The wrist is going to be flexed. The thumb is going to be adducted. Flexion of the interphalangeal, extension of the metaphalangeal. Now, I would highly memorize the wrist flexion, the forearm pronation, and the elbow flexion. Just these three. So this is a Volkmann's ischemic contracture. Now, the difference between cubitus varus and cubitus valgus. Always remember, cubitus varus is usually associated with a supracondylar fracture. This gives you the famous gunstock deformity. While cubitus valgus, look at this letter L. Cubitus valgus is associated with a fracture of the lateral condyle. Okay, lateral condylar fracture. This is how we differentiate cubitus varus and cubitus valgus. So please take note of that. Okay, please take note of that. Now, look at the bones of the forearm. Here's the freaking elbow joint. Here's the wrist joint. Here's the carpals. Always orient yourself as to the ulna and the radius. Okay, now, very important anatomic correlate. What do we call the fracture of the radius? And there is an inferior dislocation of the ulna. That is a Galeazzi's fracture. Okay, that is a Galeazzi's fracture. What about an ulnar fracture and a superior dislocation of the radius? That is now a Monteggia's fracture. Just memorize this mnemonics. Grimus, G for Galeazzi, RI, radial fracture, inferior dislocation, M, that's Monteggia, that's an ulnar fracture, USS is a superior dislocation. What is your mnemonics again for the radius and ulna fracture dislocation? The mnemonics is Grimus. Okay, so please remember that. Now, question, what specific type of fracture do we see in children? Okay, what specific type of fracture do we usually see in children wherein the bone will bend instead of breaking? So the bone will bend instead of breaking. Very good. That is a green stick fracture. Okay, bend instead of breaking. Now, what do we call an isolated ulnar shaft fracture? So we mentioned a couple of keywords here. One is the green stick fracture, commonly seen in children. It's the bending of the bone rather than breaking, because the bones of pediatric age group are usually pliable. So what do we call an isolated ulnar shaft fracture? Very good. This is known as a nightstick fracture. Okay, this is known as a nightstick fracture. So I want everyone to remember that. Okay, now what type of fracture presents with a dinner fork or a silver fork deformity? Dinner fork or a silver fork deformity. Very good. This is known as a Colles fracture. Okay, Colles fracture. That is a dinner fork or a silver fork deformity. Please take note of that. Now, question. What do we call a buckle fracture? Okay, a buckle fracture, okay, of the forearm. What is the other name of a buckle fracture of the forearm? This is what we call a torus fracture. Okay, a buckle fracture of the forearm. This is known as a torus fracture. Again, you usually see this in children. Okay, you usually see this in children. So please take note of this. Now, what's the first bone to ossify? It is the clavicle. And this is through intramembranous ossification. Okay, intramembranous ossification. So please take note of that. Now, where actually is the most common location of a clavicular fracture? It's going to be at the junction, okay? It's going to be at the junction of the middle and the lateral third. A junction of the middle and the lateral third. That is the most common location of a clavicular fracture. Now, question. Which of the muscles connects the scapula to the humerus, but is not part of the rotator cuff? What are the two? What are the two muscles that connects the scapula to the humerus, but are not part of the rotator cuff or do not take part in the rotator cuff? So we have the deltoid and we have the teres major. Question. Does the deltoid and the teres major share the same nerve supply? Yes or no? What is the nerve supply of the deltoid? What is the nerve supply of the deltoid? The nerve supply of the deltoid is the axillary nerve. What's the nerve supply of the teres major? Again, what is the nerve supply of the teres major? Not minor, but the teres major. The innervation of the teres major. What is the nerve supply? Okay, the nerve supply is going to be C5 all the way down to C7. This is known as the lower subscapular nerve. Okay, that is the lower subscapular nerve. Very good. Okay, the lower subscapular nerve. So please take note of this. Please take note of this. So what takes part in the rotator cuff. What's the mnemonics for the rotator cuff muscles? S. What's the mnemonics? S, I, T, S. What teres muscle takes part in the rotator cuff? Which teres muscle? It's the minor. Okay, the teres minor. Very good. Now, be sure you know how to identify the landmark, which is the spine of the scapula. Above that is the supraspinatus. Below it is the infraspinatus. And below the infraspinatus, we have there the teres minor. Now, the deltoid. Always remember where the deltoid is inserted. The deltoid is inserted in the middle of the lateral surface of the humeral shaft. It is inserted in the middle of the lateral humeral shaft. So please take note of that. Now, always remember by heart the following pearls. All of the rotator cuff muscles are inserted into the greater tuberosity. The exception is the subscapularis. Why? The subscapularis is inserted into the lesser tuberosity. And always remember, the subscapularis has a very unique action. What is that unique action of the subscapularis muscle, which no other rotator cuff muscle can do? And that is internal rotation. It is the medial or the internal rotation. The only medial or internal rotator of the rotator cuff is the subscapularis muscle. Memorize that by heart. And as to specific movement, particularly shoulder abduction, always remember shoulder abduction, the first 15 degrees. What muscle is responsible for the first 15 degrees of shoulder abduction? Repeat that over and over and over again. What muscle is responsible for the first 15 degrees? It is the supraspinatus. What muscle takes over after the first 15 degrees? It is now the deltoid. Okay, so if someone has inability to shoulder abduct, pero kaya nila, they can perform the first 15 degrees, but they cannot do shoulder abduction beyond 15 degrees. So take note, try to picture this out. You have a patient who cannot perform abduction beyond 15 degrees. Question, what nerve is damaged? Analyze. It's the axillary nerve. Why? What muscle has just lost its nerve supply? It's the deltoid. Okay, so please take note of that. Now, additional pearls to take with you in any standard exam, and if you want to top the board exam. In shoulder dislocations, the difference between anterior and posterior dislocation depends on where the humeral head is positioned. So what is the landmark for differentiating anterior and posterior shoulder dislocation? It's the humeral head. If the humeral head is in the subcoracoid position, that's an anterior dislocation. If the humeral head is in the subglenoid position, then this is a posterior dislocation. Now, I'm going to jump to the lower extremities. How would you differentiate a posterior versus an anterior hip dislocation? What important ligament is the landmark? This time, it's going to be the femoral head. What is the position of the femoral head as it is oriented to this important ligament? In fact, this is the strongest ligament of the body. We're talking about hip dislocation. That is the famous iliofemoral ligament. What is the iliofemoral ligament named after? What's the eponym? It's the iliofemoral ligament of Bigelow. Okay, the iliofemoral ligament of Bigelow, also known as the Y ligament. So going back to the shoulder, if the shoulder is dislocated, what nerves can be injured? It's axillary and it's the radial nerve. Okay, now question. Ill-fitted crutches. That is the exact word in the book. What nerve is damaged? Ill-fitting crutches. Very good. It's the radial nerve. It is not the axillary nerve. It is not the axillary nerve. Ill-fitting crutches. So please take note of that. Now, memorize this by heart. This is the rotator cuff. Okay, this is the rotator cuff. The deltoid is not part of the rotator cuff. What is the nerve that supplies the rotator cuff and the deltoid? It's the axillary. Okay, so the axillary nerve supplies the deltoid. It also supplies the teres minor, which is part of the rotator cuff. I strongly encourage you to memorize what muscles are innervated by the axillary nerve. Now, do you remember this blue structure here? This is known as the quadrangular space, bounded by superiorly, not seen here, that's the subscapularis. Laterally, we have the humerus. Inferiorly, nandito sa baba, right here, this is the teres major. And medially, we have the long head of the triceps. Question, what is found inside? What important structures are found inside the quadrangular space? It's the axillary nerve and the posterior humeral circumflex artery. Okay? The posterior humeral circumflex artery. Everyone has to memorize this if you want to crack the exam. Okay? If you want to crack the exam. So this is what I want you to remember. Now, very important structure. This is the deltoid. Let me put an X here. This is the pectoralis muscle. Look at this. Pex is here. There is a groove a narrow groove which is created as the pectoralis major and the deltoid muscle comes in contact with each other. What do we call this groove? It's called the deltopectoral groove. Question, what important blood vessel is found traveling or traversing through the deltopectoral groove? What blood vessel? It is the cephalic vein. So please take note of that. Now look, let's talk about the axillary artery. What muscle divides the axillary artery into three parts? It is the pectoralis minor. This structure here, okay, look at this, there, it's cut. The pectoralis minor divides the axillary artery into the first, the second, and the third part. Okay, now identify this muscle. Very close to the first rib. What is this muscle highlighted in green? Okay, that is the subclavius muscle. Okay, that is the subclavius muscle. Now, question. What is the nerve supply of the muscle that is highlighted in yellow? What is the nerve supply of the muscle that is highlighted in yellow? So that's the pectoralis minor. What is the nerve supply of the pectoralis minor? The pectoralis minor is the medial pectoral nerve. Would anyone here happen to remember what is the medial pectoral nerve? It's C1. This is C, fill in the blanks. This is C8. It's T1. Okay, C8, T1. So please take note of this. C8, T1. Now, what is the nerve supply of the serratus anterior? What is the nerve supply of the serratus anterior? It is the long thoracic nerve. Okay? Do not even attempt to go to bed if you do not remember that. Long thoracic nerve supplies the serratus anterior. And if there's injury to the long thoracic nerve causing paralysis of the serratus anterior, this results to what condition? This is the famous winged or winging of the scapula. Okay, winged or winging of the scapula. Now, the biceps brachii has two very important heads. It would be prudent for every medical student to take note of the origin of these two heads because it's different. The long head, I'm going to put a letter L here for the long head. It originates from the supraglenoid tubercle of the scapula. The short head originates from the coracoid process. So please memorize that by heart. Okay. Now, what is the action of the biceps brachii? Is it flexion or extension? What is the action of the biceps brachii? Okay, the biceps brachii is a very strong, not the strongest, but a very strong flexor. It is a flexor. And what does the biceps brachii do? Does it pronate or does it supinate? Does it pronate or does it supinate? Very good. It supinates. Okay. Now look at the coracoid process. Look at this pointer here. Coracoid process. Okay, what originates from the coracoid process? Okay, what originates from the coracoid process? Long head, short head. What originates from the coracoid process? It is the short head. Okay, the short head. Question. What nerve from the brachial plexus would pierce the coracobrachialis? What nerve? What nerve of the brachial plexus would pierce the coracobrachialis? It is the musculocutaneous nerve. The musculocutaneous nerve. Now, please memorize the actions of the biceps brachii. Look at the muscle-colored green. Take note, there's the coracoid process there. Okay, know the difference between the origin of the short head and the long head. And take note, it's supination of the forearm, it's flexion of the elbow. Okay, and it is innervated by the musculocutaneous nerve. It is innervated by the musculocutaneous nerve, but it is not pierced. The word in the textbook is pierced. One more time. What muscle is pierced by the musculocutaneous nerve? What muscle is pierced by the musculocutaneous nerve? It is the biceps brachii. Now here at the coracobrachialis, okay, it is the coracobrachialis. Now the coracobrachialis also originates from the coracoid process. Now, summarize. What are the two muscles of the arm that originate from the coracoid process? What are the two muscles that originate from the coracoid process? Number one, syempre, is the coracobrachialis. What is the other muscle that originates from the coracoid process? It's specifically the short head of the biceps brachii. Okay. Coracobrachialis is pierced by the musculocutaneous nerve. It is also, syempre, innervated by the musculocutaneous nerve. Now, what about the brachialis? Look at the brachialis here. Where is the brachialis inserted? It is inserted into the coronoid process of the ulna. Coronoid process of the ulna. Now, always remember this. What are the three major flexors of the arm? Can you enumerate three major flexors of the arm? Brachialis, biceps brachii. One more, you have the coracobrachialis. What is the common nerve supply of these three flexors? Common nerve supply is the musculocutaneous nerve. That is how you're supposed to bring this with you to your examination. The three flexors of the arm: brachialis, biceps brachii, coracobrachialis, they share the same nerve supply, which is the musculocutaneous nerve. Now, what about the triceps? Is the triceps found in the anterior or the posterior compartment of the arm? Where is it found? Anterior or posterior compartment? This is found in the posterior compartment. Now, triceps means it has three origins: long head, lateral head, and the medial head. Please remember that. Now, tip, it's not the origin that's going to come out. It is the insertion. Why? Three heads inserted into the same structure. Where is the triceps? All three heads. Where are all three heads of the triceps inserted? Again, where are all three heads inserted? It's the olecranon process. All three heads of the triceps are inserted into the olecranon process. That's why elbow injuries usually result to weakness of the triceps muscle, because all three heads of the triceps are inserted into the olecranon process. Now, the cubital fossa, oh boy, do not attempt to sleep if you do not know what are the boundaries of the cubital fossa and, of course, what is found inside. What is found inside this potential space or fossa? So we have the pronator teres, okay? Then we have the brachioradialis. Then we have an imaginary line which connects the epicondyles. Question: what is the medial boundary of the cubital fossa? What is the medial boundary of the cubital fossa? Why am I mentioning this? Because this is the muscle that is usually injured. Okay? When someone tries to slice you with a knife, it's most likely the pronator teres that's going to be injured because it serves as the medial boundary. Okay? Now, does everyone remember this? These are the carpal bones. Now, tip: know which is proximal, know which is distal. Know which is proximal, know which is distal. Always remember this famous mnemonics: scared lovers try positions that they cannot handle. My strong advice is to memorize the proximal. If you memorize the proximal automatically by the process of elimination and testmanship, you also memorize the distal. Why memorize the proximal? Because if you count and use your body as an atlas, you're going to start with the proximal first. And the second reason why I strongly encourage the proximal is because clinically, the most common fractured carpal bone is what? What is the most common fractured carpal bone? It's the scaphoid. The most common fractured carpal bone is the scaphoid. What is the most common dislocated carpal bone? Dislocated carpal bone is the lunate. Fractured is the scaphoid. Now, question: which carpal bone, if fractured, will injure the ulnar nerve? Which carpal bone, if fractured, will also injure the ulnar nerve? It's the hamate. So usually they teach you so many things to memorize, but dude, trust the master guru. This is what's clinically important. So one more time: most common carpal bone fractured, it's the scaphoid. S, scaphoid. Sikat, which in Filipino means popular. Next, most common dislocated carpal bone. Dislocated sounds like dislocated from reality. They are the lunatics, lunate bone. Hamate, okay, which is distal. This, if injured or fractured, would also injure the ulnar nerve. My personal mnemonics here is Doctor Who. What? Who? So, hamate is fractured. What should you hear? Who? What? That is HU. Hamate is ulnar. Now, if the scaphoid is injured, what blood vessel is most likely going to be injured? If the scaphoid is injured, you would most likely injure the radial nerve. So let's go clinical. Scaphoid fracture, usually falling on an outstretched hand. Scaphoid bone is the most commonly fractured carpal bone. It's usually going to injure the radial artery. So clinically, there is going to be pain and tenderness in the area of the anatomical snuff box. This is the anatomic snuff box. What blood vessel would you be able to feel, okay, if you palpate the anatomic snuff box? What blood vessel is this? What is this? This is the radial artery. You can feel the pulse of the radial artery in the area of the anatomic snuff box. Now, tip, do not even attempt to sleep tonight if you don't memorize the boundaries of the anatomic snuff box. So we have, these are tendons. Extensor pollicis longus. Pollicis means thumb here. That's the medial border. The lateral border, you're going to have two tendons. Extensor pollicis brevis and abductor pollicis longus. Proximal border is going to be a bone, which is the styloid process of the radius. So here, I made this table for you guys that if there's a scaphoid bone fracture, the radial artery is going to be damaged. If it's a hamate bone fracture, it's the ulnar nerve that's going to be damaged. So if the ulnar nerve is going to be damaged, there's inability to oppose the fingers or spread the fingers. Decrease hand grip. Radial artery is going to be injured. This is going to lead to avascular necrosis of the scaphoid. Now, I want you to remember, don't forget Kienbock's disease. Kienbock's disease is avascular necrosis of the carpal bones. Kienbock's. Okay? So please take note of that. So I want to end with this. The brachial plexus. Now, children, the brachial plexus starts from C5 and it ends where? What is the end of the brachial plexus? It's C5 hanggang where? It's up to T1. Now, tip. C5, C6, this is called upper brachial plexus. Upper trunk injury is C5, C6. C8, T1. What do we call C8, T1? What do we call C8, T1 of the brachial plexus? C8, T1, that is the lower brachial plexus. Okay, now look at this. This is the most common type of trunk injury in the brachial plexus. Involving C5, C6, that's the upper trunk. That is also known as Duchenne's palsy or Erb's palsy. That is the famous waiter's tip. This is usually associated, the history physical exam is usually a forceful pulling of the head during delivery. So obstetrical complication. And there's going to be a downward displacement of the hand. There's the waiter's tip. That is upper trunk injury. Lower trunk injury. This is our last one for this session. Lower trunk injury involves C8, T1. This is known as clumpies. There is going to be forced abduction of the arm, like what you see here. There's going to be a claw hand, okay, with a possible concomitant ape hand deformity. Now, tip, C8, T1, particularly T1, involves the autonomic nervous system. This presents with Horner syndrome. Does everyone see this little girl's eye? Okay, Klumpke's paralysis is associated with Horner syndrome. What is Horner syndrome? This is PAM. What is Horner syndrome? PAM. There's ptosis. There's drooping of the eyelids. That's ptosis. There's anhidrosis. So there's loss of sweat. Okay. And there's meiosis. Okay, there's going to be constricted pupils. This is a must know. Ptosis, anhidrosis, and meiosis. Horner's syndrome. Horner's syndrome involves, okay, the parasympathetic sympathetic chain. This is also associated with apical lung tumors, tumors which are found in the apex of the lung. Would anyone happen to know what we call this apical lung tumor? Okay, what tumor is this? Okay, perfect. This is called a Pancoast tumor. Again, this is called a Pancoast tumor. Very good. Okay. So let's now stretch. I hope you got something from this session. Thank you for the trust. Thank you for the time. This is the Master Guru saying, have a great evening. Happy studying. Happy Aral.